Welcome back, everyone. We're jumping straight into a fascinating micro to macro pharmacology journey today. We are unpacking an absolute heavyweight in the antifungal world, GRESIOFLIVIN. Whether you're actively treating patients, studying for your boards, or you just really love geeking out over how medicines interact with the body at a cellular level, this explainer is for you. We're going to break down exactly how this drug works, starting from its raw chemistry all the way up to how it's actually prescribed in the clinic. Let's get to it.
All right, here's our roadmap for today. We're hitting molecular structure and classification first, moving into its dual mechanism of action, checking out clinical indications, reviewing the safety profile, and finally wrapping up with dosage and administration considerations.
Okay, Section 1, Molecular Structure and Classification. Let's start small, like molecularly small. So if we look at its classification, GRESIOFLIVIN belongs to a very specific antifungal drug class. It's a spirobenzofuran derivative. Yeah, I know it's a total mouthful, but that unique spiral ring structure, it basically acts like a highly specialized molecular key, which gives it some pretty incredible capabilities. It completely separates GRESIOFLIVIN from your standard over-the-counter azoles or allylamines. And building on that classification, here is the exact chemical blueprint, C17H17ClO6. It's this precise arrangement of carbon, hydrogen, chlorine, and oxygen that acts as the drug's biological armor. It allows the molecule to survive digestion, travel safely through the bloodstream, and perfectly lock into its target inside those fungal cells. Section 2, Dual Mechanism of Action. Now that we know what the molecule actually looks like, let's see how it behaves in motion to fight off an infection. The really cool thing here is that GRESIOFLIVIN doesn't just do one thing. It operates via a sequential two-step combo. First, down at the cellular level, it binds to tubulin and inhibits the mitotic spindle. Second, at the tissue level, it specifically accumulates in our carrot-enriched tissues. Picture this happening in real time. The drug binds directly to the fungal tubulin, completely scrambling the microtubule spindle formation. By doing this, it stops fungal mitosis, or cell division, absolutely dead in its tracks. But that's only half the magic. The drug then travels straight to the skin, hair, and nails, our keratin-rich tissues. As it piles up there, it literally builds a fortress wall, physically blocking the fungus from invading any deeper into the newly formed, healthy tissue. And this brings us to a huge clinical distinction. GRESIOFLIVIN is classified as having a fungostatic effect. It is not fungicidal. It doesn't just nuke the fungus on contact. Actually, think of it more like a medieval siege. It halts the growth and builds that defensive keratin wall. It basically just starves the infection of new territory, trapping the fungus in the older outer layers of skin or nail, which your body naturally just sheds away over time.
Section 3, Clinical Indications for Use. Let's zoom out from the microscope and step into the clinic. What are we actually prescribing this for? We're looking at some very systemic treatment applications here. Moving systematically from the top of the body all the way down to the toes, GRESIOFLIVIN is indicated for a whole variety of dermatophyte infections. Up top, you've got Tinea capitis, or scalp ringworm. Moving down, Tinea corporis, body ringworm. In the groin area, it treats Tinea cruis, better known as jock itch. Down at the feet, Tinea pedis for athlete's foot. And finally, onychomycosis, which is that incredibly stubborn fungal nail infection. Basically, because the drug targets keratin, anywhere you have skin, hair, or nails, this stuff goes to work. Section 4, Safety Profile and Contraindications. This is absolutely critical when we're dealing with a systemic antifungal that's traveling throughout the entire body. We've got to split the side effects into two distinct camps. On one hand, you have the common, everyday nuisances, headaches, GI distress like nausea, and photosensitivity, so definitely warn your patients about the sun. On the other hand, the rare but severe risks are no joke. We're talking hepatotoxicity, severe skin reactions like Stevens-Johnson syndrome, and blood dyscrasias. Oh, and a super fascinating and vital clinical pearl, it causes a disulfiram-like reaction with alcohol. That means if a patient decides to throw back a beer while on this medication, they are going to regret it immediately and get violently ill. Because of those severe risks, we have some hard and fast contraindications. It's an absolute no-go for patients with porphyria and those with severe liver disease. Also, and I really want to put a massive underline beneath this, it is fundamentally contraindicated in pregnancy and lactation. GRESIOFLIVIN is a Category X drug, meaning the proven fetal risks far outweigh any potential benefits. And obviously, steer clear if there's any known hypersensitivity.
Section 5, Dosage and Administration Considerations. The final stretch. how does a clinician actually dose this out and monitor the patient's progress?
Dosing protocols vary pretty wildly depending on the patient's age and size. For adults, clinicians usually go with a flat dosing guideline, typically 500 to 1,000 milligrams a day. And the timeline here is huge. Treatment lasts anywhere from 2 to 8 weeks. But for kids, well, a flat dose just isn't safe. You have to use weight-based metrics, specifically prescribing 10 to 20 milligrams per kilogram of body weight per day. Now, here is one of the absolute wildest parts of the administration. You literally have to tell the patient to take this with a fatty meal. Seriously, this might be the one time a doctor actively tells a patient, hey, go eat a cheeseburger or a huge scoop of peanut butter. Because the drug is so poorly soluble in water, pairing it with a high-fat meal massively increases its absorption in the GI tract. If they skip the fat, a huge chunk of that dose just literally goes to waste. Finally, we have to talk about patient monitoring. Remember how we said this drug is fungus static and they're taking it for 2 to 8 weeks? You have to continue treatment until the fungus is 100% cleared and fully replaced by new healthy tissue. Because of that prolonged systemic exposure, strict toxicity monitoring is mandatory. Clinicians absolutely have to monitor liver enzymes and run a complete blood count, a CBC, just to make sure there's no silent liver damage or blood dyscrasias brewing behind the scenes.
So that leaves us with the ultimate real-world challenge. The molecular pharmacology is brilliant. The dual mechanism of action works wonders. But your patient has to take this pill for up to 2 months, remember to eat a fatty meal with it every single time, strictly dodge alcohol, and actually show up for mandatory blood tests. How do you ensure patient compliance? Because if they quit the second the itching stops, before that fungus-static keratin barrier has fully pushed out the infection, the fungus is just going to bounce right back. It's a prime example of how even the best pharmacology falls apart without rock-solid patient communication and adherence. How are you going to keep your patients on track? Definitely something to chew on. Thanks so much for joining me on this explainer, and we'll see you next time.